Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
All right, welcome to AUA News Inside Track. I'm David Penson. I'm the Secretary of the AUA, and I'm also the Chair of the Department of Urology at Vanderbilt University Medical Center. I'm really happy to be here today with Dr. H. Gilbert Welch, who's going to be our Ramon Guiteras lecturer at the AUA 2026 annual meeting in Washington, D.C. this year. Dr. Welch, thanks so much for joining us.
Well, David, thank you so much for having me. And I just want to say I'm honored and look forward to talking to a bunch of urologists.
Well, we're lucky to have you. You know, I'm really familiar with your background. I've been a fan of your work for a long time, as I think you know, but I'm not sure all of our listeners know who you know much about your background. So maybe you can tell us a little bit about your background.
Sure. I'm a primary care practitioner, which is why I'm so honored to be invited to a group of surgical specialists. I was a general medical officer in the U.S. Public Health Service at the beginning of my career, so I did a little bit of everything, including a little bit of surgery, appendectomies, and delivering babies and taking care of young children. But I'm also a general internist now. I mean, soon after that, I did my training in Salt Lake, at the University of Utah, and then I went on to the University of Washington, where I was very fortunate to be a Robert Wood Johnson Clinical Scholar in the Seattle program. And I moved to Dartmouth in 1990 and met a radiologist that really changed my career. His name was Bill Black, and he, had learned on chest x-rays. And we were just beginning to start spiral CT at that time. And he said, the difference is unbelievable. All of a sudden we see things that we never saw before. And, all of a sudden what was a simple read now involved multiple layers and much smaller things. And he said, if you look harder, you find more. And I said, wow, that's kind of a general problem in medicine, isn't it? It's not just about the move from chest x-ray to CT. It's about all the advances in diagnostic technology. And that got me started on, what really became the bulk of my career, the whole question of how hard should we be looking for things to be wrong?
Yeah, I mean, you sort of took away my first question and asked you how you got into this area. And I'm really excited because I think some of your views are going to be contrary to some of the urologist views.
Sure.
But having read a lot of what you've written, I think that your approach is very balanced. And I think it's going to be really interesting to see how people respond and the questions you get from the audience. One of the things I know you've written a good bit about, you've written with one of my mentors, Peter Albertson, is prostate cancer screening. So tell me a little bit, things have changed in the last decade. We've had, the USPSTF go from an I to a D to a C.
It's like the stock market. It goes up, down, you don't even know. Yeah.
We've got new biomarkers. We've had now the field itself has changed because we're doing a lot more active surveillance. How have your views evolved in prostate cancer screening?
Well, I want to be clear that I hand it to the urologist to actively deal with the problem that's one of my greatest concerns, and that's the problem of overdiagnosis. And I want to make sure our listeners know what I'm talking about there. Overdiagnosis refers to the detection of a cancer that otherwise the patient would never know about, would never develop symptoms from, or never die from. And that term overdiagnosis does not belong to me. It's not something I coined. It probably comes from the lung cancer screening literature with chest x-rays, but it clearly began to become in the general vocabulary of physicians because of prostate cancer screening. I think it was prostate cancer screening when it first starts around 1990, a little earlier than that. All of a sudden, there were all these cases of cancer, and you had a dramatic change in U.S. incidence rate. So I really say that prostate cancer screening became the poster child for overdiagnosis. It was, as I say, the word developed elsewhere. But the urologists, I think, responded to it. They first recognized that we shouldn't be screening men with limited life expectancy. They can only experience the harm, they cannot experience the benefit. And as you mentioned, you guys also started the idea of following patients with low risk disease instead of initially treating them. And I think active surveillance was a step forward. So I've enjoyed seeing how things have changed with time. At the same time, as you say, all the new biomarkers and stuff has just added a whole new level of complexity to the screening process, and means that patients have to go through more stuff. And so I'm still very concerned that we're doing too much to people who are well.
Yeah, it's interesting you say that because as someone who lives in the prostate cancer world, I think active surveillance is great. But knowing you have a low-grade prostate cancer means you're, particularly a younger gentleman, you're committed to years of biopsies and PSAs and MRIs. And so we've improved, but maybe we still have a ways to go.
Well, and you still may be drawing too many people into the process. And one of the things I think it's certainly an improvement to be more conservative on who you intervene on. But I think it's important to go back upstream and ask the question, who do you test? And at what point do you say something's abnormal? Screening is, it sounds like something simple, but in fact, it's really one of the most complex things we do. There are all sorts of decisions being made. At what age do you start? At what age do you end? How often do you screen? What constitutes an abnormal test? What should trigger further evaluation, and so on and so forth.
Yeah, I mean, they're great points. And, there's also an issue about, incidental detection, maybe less important in prostate cancer, but it's become a big deal in kidney cancers, and you've written about this around CT imaging and the incidence of kidney cancer. And there's a distinction, I think, between screening and incidental detection. Can you tell us why that distinction is important, and how do we approach this going forward when we're talking about incidental renal masses found on CT scans, which urologists see all the time?
I know. And I think it is important to distinguish the two in terms of their purpose. One is very purposeful. That's screening. We're trying to find things. Incidental detection is totally different in its intent. You're not trying to, you're stumbling onto something. It's accidental. But the commonality between the two is they both lead to the same result. That is, patients without symptoms of cancer are getting diagnosed with cancer. And so they have a lot of commonalities in their end result.
Yeah, I mean, I think it's a real challenge for us as urologists to deal with these, patients who go to the emergency room, have a little belly pain, and they come up with a 1.5 centimeter renal mass. And what do you do with that? And again, you're seeing active surveillance there, but you're exposing them to years of CT scans. So it's a tough situation. In this case, we're not even trying to do it.
It's not purposeful. And it's one of the reasons that, and this is less on the urological specialty, but it's on the general medical specialty. We need to be hesitant to cross-sectionally image people. I mean, I want to be clear, well, let me just say, if I may, I hope to go through life without having a cross-sectional image. Just because I know I'm a treasure trove of abnormality, but I will also gladly jump in a scanner if I have a motor vehicle accident and I'm bleeding, or If I have an acute abdomen, maybe a perforated viscus, these are great technologies. It's not like the technology is good or bad. The whole question is under what conditions do you go into them? And I think in general, there's way too much scanning. There's too much imaging right now, and it leads people to have problems, a lot of uncertainty, a lot of stress, a lot of logistical nightmares following things up. And increasingly in this country, it makes people poor. So we've got to be careful about unearthing things, just because we're trying to check everything out.
Yep. Well, I want to change the topic a little bit to something that I find really interesting that you've written about, and as a prostate cancer specialist, something that I don't know. I don't know if we're doing the right thing. You've written a lot about surveillance after diagnosis and treatment when you're looking for recurrences and metastases. And obviously, we do a lot of this in urology. We've got PSA screening, we've got serial CT scans. Now we have circulating DNA testing. I mean, and we're going to see more. So, are we doing the right thing? And if and what are the harms of doing it?
Yeah. Well, first, this is a very good question. And the whole question of what we do in patients who have been treated for cancer, how aggressively we look for recurrence of that cancer. And that's what surveillance is. It refers to patients with known disease who have presumably been treated for their disease, and we're looking to see if something has recurred. And the bottom line is, as I had a piece with Leslie Dossett in the New England Journal on this, is that what trials have been done of recurrence are totally unsupportive of the practice. It makes no difference in people's risk of death. The fact is, if you've had cancer and you recur, that's a bad disease. No question about it. That's a bad disease. The question is whether finding that recurrence a few months earlier makes any difference in the outcome. And the places it's been studied, it does not. And that's why in breast cancer now, there's broad agreement that we shouldn't be looking for distant metastases in women who've been treated for breast cancer. You will find a few earlier than you would otherwise, but they live longer with the knowledge that they've recurred, and they die at the same time.
Yeah, I mean,
so I see that as a harm. I want to be clear. If all we're doing is telling people they've failed a few months earlier, that means they're exposed to treatment earlier, they're exposed to the side effects of treatment earlier at a time they would otherwise be asymptomatic and do not experience a longer life because of it.
Yeah, it's a great point. And I have to say, in urology, we kind of made it up as we go along, right?
Yeah, and in urology, I don't know of any literature.
Yeah, no, there really isn't. I always think about this with PSA follow-up after treatment. And
most of the literature is from breast and colon cancer.
Well, since you bring up breast,
yeah.
I mean, I think both in breast and maybe in thyroid cancer too, I think urologists, maybe we have a lot to learn from them. What do you think? What can we learn from our colleagues in breast and thyroid cancer?
Well, that you're not alone in dealing with this problem. I think that's what you can really learn. And I'd throw one other one in there, and that's melanoma skin cancer, which is probably now the most egregious example of overdiagnosis currently in the United States. So you're not alone. This is a problem that other specialties face. I'm not sure anyone. I mean, I'll give the thyroid cancer surgeons. I think they're the most aligned with you in urology in terms of recognizing the value of watching and seeing what happens. There's been active surveillance now in thyroid cancer, and there's also I'd say more hesitancy to scan necks for nodules, ultrasounds of the neck for thyroid nodules. They're exceedingly common. And it's one, if you look for it, you'll find it. I mean, it's a very the reservoir of thyroid cancer is considerable, and I think that community is most similar to the urology community in recognizing that's a problem. The breast cancer community, screening there, there's no screening test that's been more aggressively promoted than screening mammography, and you don't want to get me started on that.
Fair enough. Well, I will say I'm going to editorialize for a minute, not about mammography, but about thyroid cancer.
Yeah.
One of the things that they did in thyroid cancer is they changed the nomenclature, and the low-grade thyroid cancer is not called cancer anymore. And there are a bunch of us in urology. Scott Egner at UCLA is really the
Yes.
leader for this, but I'm on board 110%.
Yeah, the question is, can you get the pathologists on board?
Yep, it's a great question.
That's
I
a
wish we
really
could.
tough question, because they're also, very nervous about undercalling. They prefer to err on the side of overcalling. And I worry that changing nomenclature may change their thresholds and so forth. It's a tough problem.
I hope there are a few pathologists listening and hear you and hear me, because, gosh, it would make my life easier. And I think it would help a lot of patients.
Yeah.
Well, just to wrap up, I as you can tell, I'm really excited about having you as the Guiteras lecturers.
I'm excited to coming. Yeah.
Yeah, it is our featured keynote address, and I think it's going to be provocative, which is always good. And I think I'm hoping that the urologists who attend are going to leave with a little food for thought. So maybe you can give us a little peek without giving away the punchline about what you're going to talk about, and explain why our listeners should come and learn more.
Well, I think they'll learn a little bit about what I've learned from urology and how I taught about it when I taught medical students, because you guys gave me a lot of great material. So I hope people come also with the idea we're going to have a little fun. Sometimes there's not enough fun in this world, and these are serious topics, but there's no reason we can't have a little fun as we do it. I'll tell you a little bit about, how I think about PSA screening and what I've done for myself. So I hope people come, and I hope they're ready to have a good time.
Well, I hope they come too, and I think they will. I want to thank you for joining us, and I want to let our listeners know that you really don't want to miss Dr. Welch's lecture. It's going to be Friday morning on the Plenary at the AUA. It's in the opening session. It's going to be from 9:45 to 10:30, and come, listen. We'll even be able to take questions electronically from the audience, so I think it'll be a great session. And Gil, thanks again. I really appreciate your time.
All right. Look forward to seeing you there.
This has been an AUA News Inside Track podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.